This lecture will cover Chapter 13, where we will be talking about blood in the Human Body in Health and Disease textbook. Unlike humans, other living creatures have different colors of blood besides red. Spiders, octopus, squid, and some arthropods have blue blood, while worms and leeches have green blood, and beetles and butterflies often have a pale yellowish colored blood. In humans, about 0.2 milligrams of gold is circulating around in our blood. In addition to that, blood types vary by population. The most common blood type is O positive, and the least common blood type is AB. And in Japan, the most common blood type is A positive. The goal of this lecture will be to talk about blood composition as well as the mechanisms of blood diseases in red blood cells and white blood cells, as well as platelets and clotting disorders. Now, we already talked about in a previous lecture about tissues that blood is actually a tissue. It has a liquid part and it has a solid part. The liquid part, or the extracellular part that carries those solids, is called plasma, which we've discussed previously. And the cellular components, or the solid components that are suspended in that liquid component of blood that we refer to as plasma, makes up the formed elements. So those will be our red blood cells and our white blood cells predominantly. Now, when we're talking about how much blood do we have in our body, we have about 2.6 liters or 2.5 liters of plasma and about 2.5 liters of formed elements. So this means that when we look at blood as a whole, the plasma and the formed elements, we have between 4 and 6 liters on average. Now, when I think about how much blood we have, I often picture like a 2-liter bottle of soda. And if you can think about having about 2.5 or 3 of those, that's about how much blood we have in our body. And that's about 7% to 9% of our total body weight. About 60 to 70% of our entire body is made up of fluids. And when we're talking about blood, that makes up about 8% of those fluids. And this is a good visual here regarding the components of blood. And so we can see that plasma makes up about 55% of blood, and the formed elements make up about 45%. And then if we look at the components of plasma, we can see that it's made up of various proteins, water, and then other solutes like ions, nutrients, waste products, gases, those types of things. And then when we looked at the formed elements, we have our platelets, our leukocytes, and our erythrocytes. And this is also a good list here of the leukocytes, or white blood cells, which we will talk about a little bit more coming up. The neutrophils, lymphocytes, monocytes, eosinophils, and basophils, and they all have different jobs. But this is a good visual of the components of blood. Blood pH is a little bit on the alkaline side, with a pH of 7.35 to 7.45 being the normal range. Remember that pH scale where 7 is neutral and anything above 7 is considered alkaline and anything below 7 is considered acidic. When blood pH decreases towards neutral, this can create a condition called acidosis. However, acidosis is rare. Typically what happens is blood has a tendency to become a little less alkaline, but not acidic by the normal definition of the pH scale. When we have a patient that's in a crisis situation and they're hemorrhaging, sometimes we have to give them a transfusion. This is where blood donations come in. Approximately 14 million units are donated annually, and even though that sounds like a lot, it is not enough. Different types of pharmaceuticals like volume expanders and those types of things only work for a short period of time. Now, when you donate whole blood, that can be separated out into different components like the plasma and the packed cells. And then another interesting fact regarding storage of donated blood, that is limited to approximately 6 weeks. A couple more little interesting tidbits about blood donation. What do you think? Do donation centers sell blood? If you guessed yes, you're correct. All the centers that supply blood for transfusions sell their products to cover their operating expenses. So what happens is these local hospitals, they work out contracts with regional suppliers or their local Red Cross facility. So how much do you think blood costs? Well, that varies from place to place, but this is according to a source from 2010 that blood centers average is about $310, but depending on the market, one unit can be worth a lot more. For example, red blood cells can go for $229, platelets for $300, and plasma from $40 to nearly $570 in all. ABC News from 2010 there. To further break down the composition of blood plasma, this slide here is just talking about that those nutrients we were mentioning previously, ions such as salt are also dissolved in the plasma, and floating in the plasma as well is some dissolved gases like oxygen and carbon dioxide. As I mentioned previously, blood plasma also has proteins that are floating in the plasma. And those most common proteins are albumins and globulins. Albumins are responsible for helping retain water in the blood. So albumin can be used in patients that have low fluid volume to increase the amount of blood volume by 3 to 4 times, which it pulls water into the circulatory system through the process of osmosis, which we talked about in our AMP1 class. The globulins we've talked about previously too, and globulins help to protect us from infections. Two other components that are also in plasma are clotting factors, and these clotting factors are called fibrinogen and prothrombin. When we have a plasma that is minus the clotting factors, we call that serum. And how we get serum is we take a sample and we allow the blood to clot into the bottom, and the liquid part that is left is referred to as the serum. Now, the serum still contains antibodies, so it can be helpful in treating patients who have a need for specific antibodies. Now let's talk about the formed elements of blood. Two basic formed elements of blood are the erythrocytes and the leukocytes. The erythrocytes are our red blood cells, or RBCs, and the leukocytes are our white blood cells, or WBCs. There's two different types of leukocytes, granular leukocytes and agranular leukocytes. When we look at these different types of white blood cells under a microscope after they have been stained, there are some that appear to have these little granules. Those are the granular leukocytes. Those are neutrophils, eosinophils, and basophils. And then the agranular ones, the ones that do not have those stained granules in their cytoplasm, are the lymphocytes and the monocytes. Now, there are approximately 5 million red blood cells, 7,500 white blood cells, and 300,000 platelets in just 1 cubic millimeter of blood. And that is a lot of cells per cubic millimeter. And interestingly, red blood cells, they don't live very long. And so the body is consistently reproducing new red blood cells. About a few million red blood cells are manufactured each second. And then lastly here on this slide are the platelets. As I mentioned, about 300,000 platelets in 1 cubic millimeter of blood. And we also refer to platelets as thrombocytes, but platelets are an integral component of clotting. So when we get cut, the platelets, the thrombin and the prothrombin are the components that help us to make a clot to stop that bleeding. Here are those numbers that I mentioned before on the previous slide. And then not new to us is the word hematopoiesis. And if you remember, hematopoiesis is the formation of new blood cells. And the formation of blood cells happens in the bone marrow. And in the red bone marrow, or the myeloid tissue, all blood cells are formed except for lymphocytes and monocytes, and most all other cells are formed by the lymphoid tissue in the lymph nodes, the thymus, and the spleen. And the ones that are formed in the lymphoid tissue are predominantly those that help build our immune system, and we'll talk about that in a lecture down the road. This is an image from your textbook, and I think it's a good image for you to see the difference between these granulocytes and agranulocytes. And if you look at the neutrophils, the eosinophils, and the basophils, you can see that there's these little dark spots in the cytoplasm. And then if you look at the lymphocytes and the monocytes, you can see that that spotting is not present in the cytoplasm. So it gives you a visual of the difference between the two. When myeloid tissues and lymphoid tissues fail to produce normal blood cells, that's when we get some sort of blood disease like an anemia or a leukemia. Other factors that can cause blood disease are exposure to harmful environmental factors like chemicals and radiation, also nutritional deficiencies and various cancers, as well as different genetic mutations or genetically inherited defects. So if doctors suspect that there's some type of bone marrow failure, then they can perform a procedure called an aspiration biopsy cytology, or an ABC. And this ABC allows them to examine that tissue to help confirm or reject a tentative diagnosis. If they do determine that there is some sort of failure, then they can do a bone marrow transplant, and that is typically from hematopoietic stem cells that can help regenerate the bone marrow and produce normal blood cells. We've had several discussions about how function follows structure, and red blood cells are no different. Red blood cells are shaped in a way that allows oxygen and carbon dioxide to attach or release from itself as needed. We refer to this shape as biconcave, and if you kind of think in your mind of a donut that doesn't have a complete hole in the center, where there's this thick outer edge and thinner center, which increases its surface area. Something else that's interesting about the red blood cell is that it doesn't have any organelles in its cytoplasm, and it doesn't have a nucleus. So what this means is it cannot reproduce itself. Therefore, it lives about 80 to 120 days, and this means that the body has to continually produce red blood cells. And millions of those are being produced a day in our body so that our body and our tissues can get the oxygen that it requires. There's a lot that we can learn when we look at the formed components of blood. And when we look at all of these formed components, we refer to that as a complete blood cell count, or a CBC. A CBC, we probably all had one of those because it's a routine part of any physical examination if they're going to draw blood and take a look at it. Some of the things they might be looking at is the red blood cell count or the white blood cell count, maybe how many thrombocytes we have, the differential white blood cell count, so how many eosinophils, how many neutrophils, how many basophils, so on and so forth, hematocrit, hemoglobin, and other various types of tests that they can look at to assess the normal health of a patient. Thrown in there is also the hematocrit. And the hematocrit, also called the packed cell volume, or PCV, provides information about the volume of red blood cells in a sample. Now, a long time ago, they used to use something called a hemocytometer to get an idea of how many red blood cells there were. And it was not very accurate. It consisted of a microscope slide with a counting grid that was etched on it so that they could get a rough estimate. But now they have automated machines that do that for us, which is a lot easier and more accurate. When a hematocrit test is formed, what they do is they take the blood sample and they put it into a centrifuge that spins it really fast, and that allows the heavier components to settle to the bottom and the lighter components kind of float to the top. And the white blood cells and the platelets settle out into this lighter colored layer that we call the buffy coat. And you can see that little white line in each of these test tubes is that buffy coat, and that's our white blood cells and our platelets. And this gives us information about the possibility of an individual being dehydrated, or if they've been hemorrhaging, what that ratio looks like. A normal ratio should be about 45% of the blood volume consisting of red blood cells. So if that is shifted, then that gives us a good idea of how to treat our patient. So the primary job of red blood cells is the transportation of those respiratory gases that we talked about before, the oxygen and the carbon dioxide. Some important players here that we're going to talk about is hemoglobin, iron, vitamin B12, folate, and of course oxygen and carbon dioxide. Now this top image you see is the red blood cell. And this weird green little twisty thing that you see down below is a hemoglobin molecule. And this hemoglobin molecule is composed of 4 polypeptide chains, 2 beta chains, and 2 alpha chains. And if you see these little red dots that are located on each of those polypeptide chains, these are called heme groups, and these groups contain iron atoms. And this is important. That's why it's important for our bodies to have enough iron, because that is what attracts oxygen to the hemoglobin. And that is what increases the efficiency of these red blood cells to transport oxygen around the body for use in our tissues and our cells. Now, when an oxygen molecule attaches to one of these heme groups, it's called an oxyhemoglobin molecule. All right, and sometimes we also have carbon dioxide that attaches to the heme group, and that would be called a carbaminohemoglobin, or HbCO2. All right, so These different gases attach to the red blood cells to increase the efficiency of transport, whether it's transporting the CO2 to the lungs to be excreted, or it's transportation of oxygen to the tissues to be used so that our cells can do what they need to do. Now, some of that CO2, about 70% of it, that's carried in the blood. The red blood cells convert that to something called bicarbonate, and we'll talk about that later on in a little more detail in chapter 17, but suffice it to say for now that the CO2 is converted into something called bicarbonate, and then it is transported to the lungs and excreted there as a waste product. Here are some terms that we use to classify different red blood cell abnormalities. When we're discussing cells that are normal in size and normal in hemoglobin, we call those normocytes and refer to them as normochromic. If the cells are smaller in size or larger in size, they would be referred to as microcytic or macrocytic. And then if they have a low hemoglobin content, hypochromic, or high hemoglobin content, we'll refer to as hyperchromic. Now, in a situation where we have a patient that has chronic blood loss, we may see macrocytic hyperchromic red blood cells during these types of situations. And this is a good example, again, of a negative feedback loop. So what happens is the body is going to increase the size of the red blood cell and increase the amount of hemoglobin that each cell can carry to help restore or maintain the oxygen carrying capacity of the blood. Here are some micrographs that show normal red blood cells compared to abnormal red blood cells. So if we look at this top line, from left to right, we see a red blood cell that is hypochromic, and then on the opposite side, a red blood cell that is hyperchromic, and then what the normal one looks like in the center there. And then on the bottom, on the far left, a microcytic red blood cell compared to a normal red blood cell, and then a macrocytic red blood cell. So before we can really dive into talking about blood types, we need to understand the difference between antigens and antibodies. Now, antigens are substances that stimulate the body to make a substance called an antibody. Antigens are typically a substance that comes from the outside. The body doesn't make it necessarily. It enters the body by some process, whether it's means of infection, transfusion, or some other method, and the body responds by developing an antibody. And an antibody is a protective protein that's used to protect or defend the body against said invader or antigen. So they kind of work together in a lock and key type method. We've talked about that lock and key method before, but when we're talking about blood, first we need to understand antigen versus antibody. Remember, the antigen is a foreign substance and it causes a reaction in the body, and that reaction is for the body's immune system to produce an antibody that's going to be used to attack the invader or the antigen. So first we're going to talk about blood types, and then we will talk about the Rh system or the rhesus system or rhesus factor. Every person has a blood type, and there's 4 different types that a person can have. This is based on something called the ABO system. So someone could have type A, type B, type AB, or type O. there's a pretty good chance that you know what your blood type is. My blood type is A. And if you've ever donated blood, they will send you a complimentary card. They will type and cross you and send you a card with your blood type on it so that you can carry that in your wallet or in case of an emergency or whatever. So these are the 4 blood types that we can have. Now, remember we talked about antigens and antibodies on the previous slide. So here's where those come into play. When we have a type A blood type, that means that type A antigens are present on the red blood cell. That also means that there is an antibody for the opposite type, which would be type B. So type A blood has type A antigen and anti-B antibodies. So what that means is if it was to come across a B type blood cell that had the B antigen, it would attack it. Okay, so the next one is type B blood. Again, same thing, type B has type B antigens. It has antigens, it has proteins associated with it, that means it has anti-A type antibodies. If you give a person that has type B blood type A, the blood has antibodies to attack type A, and so the body is going to start attacking itself, and that's a bad thing. And that's why giving someone a blood transfusion that is compatible with their blood type is so significant. So moving down the line, type AB blood has both types of antigens, which means it does not have any antibodies. This is significant because we refer to type A blood as a universal recipient. They can receive any type of blood and their body won't react to it because they have no antibodies whatsoever. Remember, antibodies attack antigens or foreign invaders. And then the last type is type O. Type O doesn't have any antigens, but it has anti-A and anti-B antibodies in the plasma. Type O, we refer to it as the universal donor because it doesn't have any antigens. There isn't any foreign invader attached to its blood cells. So when you give it to someone of any type of blood, it's safe because it doesn't have any foreign invaders attached to it that somebody else's antibodies would attack, okay? In the operating room, when we have a patient that needs a transfusion, typically we're scrubbed in at the field, and so that means the nurse and the anesthesia care provider are going to work together to get the blood and to make sure that it's the right type before it is given to the patient. And then, we also have to take cultural preferences into consideration. In Jehovah's Witnesses typically refuse blood transfusions, and there are some other alternatives. And one good alternative is called the cell saver. And the cell saver allows us to suction up through a sterile suction tubing blood that is lost from the patient, and then they can actually give that back to the patient so that they're getting their own blood. So that's pretty awesome. Now we're going to talk about the RH system. The RH system, RH is short for rhesus or rhesus factor, and it gets its name because it was named after a similar protein that was found in the rhesus monkey. Now, the rhesus factor is an inherited protein that is considered an antigen, so another type of antigen now that can be found on the surface of the red blood cell along with either an A antigen or a B antigen. There can be this additional protein, and if it's there, we say the person is Rh positive. Positive means they have the protein. Negative, Rh negative blood means that there's no rhesus factor present, or there's no antigen that's located on the red blood cell. This can be of a concern when we have a Rh negative mom and an Rh positive father. If the fetus is Rh positive, then this is going to stimulate the mom's body to generate anti-Rh antibodies. Remember, the antibody is the thing that's going to attack what appears to be a foreign invader, and that's that positive antigen. So it's not as crucial with the first pregnancy, but once there is that pregnancy with that Rh positive factor, the second baby could be at risk of developing something called erythroblastosis fetalis, and we'll talk about that in a little more detail on the next slide. This can also happen in a patient that is Rh negative and they get Rh positive blood. The first time, there won't be a negative effect, but it will stimulate the body to develop those antibodies. And then the second time that the person is given an Rh positive blood, the antibodies will be there and they will attack those cells, all right, and that can cause harm to the body. Something called agglutination, and agglutination is this natural process that happens between antibodies and antigens where the antibodies cause the antigens to clump together, and this clumping together allows the body to more easily attack and get rid of those foreign invaders. Here's the image taken from the textbook regarding erythroblastosis fetalis, and this top image that you can see here of the baby. This, again, a positive father, positive Rh father, and a negative Rh mother. If the offspring is Rh positive, the mom is going to develop antibodies. It will not harm the first child, but if she were to get pregnant again and that baby were to have the positive Rh factor, then the mother's blood cells would attack the baby's blood cells, and this could lead to death. So typically when we have a mom that is Rh negative, we give them something called RhoGAM, and RhoGAM is going to stop the mom's body from forming those anti-Rh antibodies. Now we're going to move on and talk about some red blood cell disorders, and the first one we're going to talk about is polycythemia. Polycythemia is a blood disorder, and it's characterized by an increased number of red blood cells, sometimes into the 10 millions per cubic millimeter. So with polycythemia, a lot of times this is a result of cancer in the bone marrow, and there's these too many red blood cells are being produced. Can also be caused by something called blood doping, which the book refers to on page 354, something that athletes can do, also refer to it as blood boosting to help them increase their red blood cell count, to increase the oxygen that is circulating in their blood, to give them an advantage during their competition. So this increase of red blood cells is going to cause a myriad of events in the individual. It's going to cause the blood to thicken. all right? And as the blood thickens, it's going to be more viscous, and that is going to impede the flow of blood. All right, it's going to be more difficult to push that thickened fluid. Think of when you're trying to get ketchup out of one of those like old-timey glass bottles, right? It's really difficult. You know, sometimes you got to get your knife in there and stir it around, right, to get it to come out. So it's going to be more difficult for the blood to flow. The heart is going to pump harder. This is going to increase the pressure on the walls of the vessels. It could lead to rupture of vessels. It could also increase blood clots, the chance of blood clots, risk of stroke, and risk for heart attack. In polycythemia, the hematocrit could reach levels of 60%, which is way above the normal 45%. So how do we treat this? Typically, if it's a cancer, we treat it with radiation of the bone marrow or chemotherapy treatment, and they can also do something called bleeding, where they remove some of that blood to hopefully decrease the tension and increase the flow, and so on and so forth. Next, we're going to talk about some different types of anemia, but let's first define what anemia is. Anemia is a deficiency in the production of normal hemoglobin. Remember, hemoglobin is responsible for attracting oxygen to the red blood cell. So if we don't have efficient hemoglobin, then our tissues aren't going to be oxygenated efficiently. All right, so this is either not producing enough hemoglobin, or the hemoglobin that is being produced is deficient in some way, shape, or form. So again, this is going to lead to low tissue oxygenation. The patient may suffer from weakness, they may look pale, they may complain of their head hurting or feeling faint. And then again, the body always wants to maintain homeostasis, right? It wants to right the wrong that's going on inside of the body. So how is it going to do that? It's going to try to compensate with negative feedback mechanisms. And one example is an increase in respiratory rate. And a second example is speeding up the heart rate, right? If we can get blood pumped around faster, we can get what oxygen we have delivered to the tissues more quickly. Again, increased respiratory rate is going to increase the level of oxygen in the body. So some good examples of negative feedback mechanisms. Next, we're going to talk about some different types of anemia. First, we're going to talk about hemorrhagic anemia, and this is probably the most common type of anemia that we are going to see in the operating room, and it is a result of acute blood loss. So if we have someone that has sustained a sudden trauma and they're bleeding profusely, this is going to cause hemorrhagic anemia. Right, so it could also be caused by various types of cancers or ulcers, and then that would cause chronic bleeding over a long period of time. Could also be diagnosed as hemorrhagic anemia. We talked about in situations such as this where those red blood cells that are there are going to appear macrocytic, so they're going to be larger than normal, and they're going to appear as hyperchromic, so more hemoglobin, right? And this body's way of trying to maintain homeostasis. And once blood products are given, and things can return to normal for the body. Another type of anemia is aplastic anemia. And aplastic anemia is characterized by low red blood cell counts and destruction of the bone marrow. Remember, the bone marrow is responsible for making red blood cells, so if there's something that is destroying that tissue, then that's going to result in lower red blood cell counts. Oftentimes, the cause of this is environmental, where somebody has been exposed to toxic chemicals over high doses over a long period of time, such as benzene or mercury or irradiation. How do we cure this? The way we cure it or help to alleviate aplastic anemia is through bone marrow or stem cell transplants. There are also various types of anemias that can develop due to an inadequate supply of certain types of vitamins. For example, pernicious anemia results from a dietary deficiency of vitamin B12. It can also result from the failure of the stomach lining to produce a substance that allows vitamin B12 to be absorbed. So if there's sufficient vitamin B12, but it's not being absorbed, then it could be something going on there with the production of the intrinsic factor in the stomach. Genetics can also play a role in this type of disease, and one sign that we might see is that red blood cells are really larger than normal, so they're going to appear macrocytic. And in addition to the regular symptoms that we've already talked about associated with anemia, a patient might experience numbness and tingling in their extremities, like their feet and their hands. They may appear mentally impaired, they may be irritable, and depression is also a common symptom. How do we treat this? We treat this with injections of B12. Two additional types of deficiency anemias are folate deficiency and iron deficiency, and both are largely attributed to malnutrition. Folate deficiency is caused by a deficiency in vitamin B9, which causes a decreased red blood cell count. It is commonly seen in those individuals with alcoholism and, as I mentioned, malnutrition. And how we treat it is by giving vitamin supplements of vitamin B9. Iron deficiency is caused by a deficiency in iron or the inability to absorb iron. The red blood cells are going to appear much smaller and lighter in color, so they're going to appear microcytic and hypochromic. And this is because the hematocrit is going to be decreased in this situation. And how we treat this by administering iron supplements or iron compounds. Now, iron deficiency is the most common nutritional deficiency in the world, and it's estimated that 10% of the population in some developed countries, such as the United States, and 50% of the population in developing countries suffer from iron deficiency anemias. Now, hemolytic anemias are caused by the decrease in red blood cell lifespan or increase in red blood cell rate of destruction, because this is typically because of an abnormal hemoglobin, and that will cause the blood cell to become distorted or easily broken. As a result, there's going to be more of those products, those waste products associated with the breakdown of red blood cells, and that can lead to something called jaundice, which is kind of a yellowish brown appearance to the skin because of those increased waste products. The patient may also have an enlarged spleen or gallstone formation. We might also see iron deposits in the tissues. That's also related to the breakdown of the products that are associated with the breakdown of red blood cells. Sickle cell anemia is a genetic disease, and it results in the formation of limited amounts of abnormal type of hemoglobin called sickle hemoglobin or hemoglobin S. Because of this genetic mutation, there is a substitution for one amino acid on the beta polypeptide chain. Remember when we talked about hemoglobin, we said it was a 4-protein molecule with 2 alpha chains and 2 beta chains. So here we're getting a substitute amino acid on one of those beta chains, and this makes the red blood cell less stable. And because of that, it kind of forms into this sickle or crescent shape when the blood oxygen level is low. So if a person inherits one defective gene, we refer to this as sickle cell trait. Those individuals probably don't have any symptoms at all. If we have an individual that inherits 2 defective genes, one from each parent, this is a more serious situation, we refer to as sickle cell disease. Because of the severity of it, it can potentially lead to death. It increases risks of blood clotting, and it impedes the blood flow through the vasculature. Unfortunately, there aren't any drugs that prevent the sickling of these cells in these individuals, so we rely on patient education and early diagnosis and preventative measures to increase survival rates. Approximately 1 in every 600 African American babies are diagnosed with sickle cell trait or disease. And here's an image of what that sickle-shaped red blood cell would look like. Thalassemia refers to a group of inherited hemolytic anemias, and the most common type, which occurs most often in individuals of Mediterranean descent, is often characterized by the production of abnormal hemoglobin or an inadequate number of small, oddly shaped red blood cells that don't live very long. Similar to sickle cell, there are 2 types, mild and severe. Thalassemia minor or thalassemia trait occurs when that one defective gene is inherited, and thalassemia major occurs when 2 defective genes are inherited, and this can become a very serious, life-threatening type of hemolytic anemia. Typically, in these individuals, we see bone marrow mass expanding. This is because of that low oxygenation, right? The tissue is going to start to expand and try to enlarge those cells that are there and present and working effectively. This can lead to crippling and other various skeletal deformities, and unfortunately there is not a treatment, a successful treatment as of yet, but some ways they are treating is with bone marrow and stem cell transplants, and they are working with some experimental procedures for gene manipulation, and they are seeing some promising results with that. So now we're going to shift our discussion towards leukocytes or white blood cells and away from red blood cells. White blood cells, when they are stained and looked at under a microscope, have kind of these interesting and kind of crazy shapes. As you can see in this image here, their nuclei are very strangely shaped. They, unlike red blood cells, they do have nuclei. They do have some of them have granules in their cytoplasm. They do not contain hemoglobin, so when they're not stained, they have this clear appearance, and when they clump together, kind of like when snowflakes clump together, they take on this whitish kind of appearance. Now, the normal white blood cell count is approximately 5,000 to 10,000 per millimeter cubed of blood. When we have an individual that has an abnormally low white blood cell count, we refer to this as leukopenia. And leukopenia is rare, and it may result as a form of malfunction of the tissues that support the immune system and produce white blood cells, and also because of some diseases such as acquired immunodeficiency syndrome. Leukocytosis is the opposite of leukopenia. So remember, we said leukopenia is abnormally low white blood cell count. Leukocytosis refers to an abnormally high white blood count that's typically more than 10,000 white blood cells per cubic millimeter. This is a good determinant of bacterial infection being present. And you can see a couple pictures I posted here on this slide. The top one is an inflamed appendix, and the other one that you're looking at is inside the abdomen, and this is some kind of exudate. It doesn't quite look like it's pus, but it's definitely some signs of infection going on there. So if the white blood count is elevated, that typically means that there's some type of bacterial infection going on. Another test that we can perform in regards to white blood cell count is called the differential white blood cell count. And this gives us some good information regarding the proportions of each type of white blood cell in the sample. Not always do we see a high white blood cell count, but we might see a higher proportion of one to the other. And a good example is sometimes when an individual is infected with a parasite, we will see an increase in eosinophils, which specialize in defending parasites. So that could clue us in to a proper diagnosis. Now let's talk about the different functions of each leukocyte. So first we'll talk about the granulocytes, and then we'll move on to the agranulocytes. Neutrophils is first on our list, and they're the most numerous type of active white blood cell, and they perform something called phagocytosis. Remember, phagocytosis means cell eating, if you remember back to medical terminology. So basically they take in different particles, maybe invading microorganisms, and they engulf them and they process them and digest them for us. And these are all part of our immune system and very important in protecting us from these foreign invaders. Eosinophils are similar to neutrophils, but they're not as strong phagocytes as neutrophils are. One important thing that they do, we mentioned previously in the previous slide, that they protect us from different parasitic infections. And they are also involved in regulating some allergic reactions, including asthma. Basophils exist in our blood and in our tissues, and they secrete something called histamines. And histamines are typically released during any type of inflammatory reaction. Another important thing that basophils do is they secrete an anticoagulant called heparin. Remember, anticoagulants inhibit the blood from forming a clot. So this reduces the chance of blood clotting and helps blood flow smoothly through the vessel. Now, agranulocytes, we refer to them as monocytes. Monocytes are the largest white blood cells, and similar to neutrophils, they are phagocytotic. All right, now they are larger in size than neutrophils, and because of that, they can take in bigger invading particles. A type of monocyte is a macrophage, and a macrophage is just a really big overgrown monocyte. Then we have our lymphocytes, and there's two different types of lymphocytes that protect us against infection, but they don't do it by engulfing particles. They do it by producing antibodies. So remember we talked about antibodies earlier in the discussion, and these antibodies attack foreign invaders. All right, so there's two types of those, B lymphocytes and T lymphocytes, and we're not going to get into them too much. We'll talk more about them in chapter 16 when we discuss the immune system in more detail. Suffice it to say, these guys make antibodies that help protect us from foreign invaders. The B lymphocytes are typically produced in the bone marrow, B for bone marrow, and the T lymphocytes are typically produced in the thymus. There are two major types of white blood cell cancers or neoplasms, and I think the book is kind of confusing when it talks about this. This is the verbiage that the textbook uses to describe each type of neoplasm. However, I think it's a little bit easier to think of lymphoid neoplasms as originating from lymphoid tissues like lymph nodes, thymus, and spleen, and then myeloid neoplasms arising from tissues such as bone marrow and the blood. Multiple myeloma is a type of cancer of the B lymphocytes called plasma cells. And plasma cells are white blood cells that originate in the bone marrow, and their job is to secrete large amounts of antibodies. So when there is a malfunction in these plasma cells, then that is going to cause bone marrow dysfunction and defective antibodies and reduced production of effective antibodies. It is the most deadly blood cancer in people older than age 65, and it is characterized by recurrent infections and anemia and bone fractures. And you can see this image of this radius ulna humerus. You can see here that it looks very pitted, very easy to fracture a bone that looks like this. It's very weak and fragile. Treatment for multiple myeloma would include chemotherapy, drug and antibody therapy, and bone marrow and stem cell transplantation. Leukemia is the term that we use to describe a number of different blood cancers affecting the white blood cells. There are 4 different types that we're going to talk about, and it is important to note that with leukemia, we typically see leukocytosis. And this first one that we're going to talk about is chronic lymphocytic leukemia, or CLL, and it most commonly affects older adults, so it's rare in individuals that are younger than 30 years of age, and oftentimes there is an onset at about 65 years of age and is more common in men than women. With chronic lymphocytic leukemia, we see an increased production of lymphocytes, B lymphocytes. However, those antibodies that they're producing are abnormal. And so this may cause some infections to occur, but typically individuals with chronic lymphocytic leukemia, they really don't have any symptoms, or they have few symptoms, and so typically this type of leukemia is diagnosed accidentally by doing some blood work or what have you. Symptoms are typically mild. They might have fatigue or show some signs of anemia. But individuals with this type of leukemia can live for several years following diagnosis and often respond very well to chemotherapy and irradiation. Next, we're going to talk about acute lymphocytic leukemia. Remember the difference between acute and chronic. That might help you on an exam if you are asked about one of these different types of leukemias. Remember, chronic typically takes a long time, and acute comes on quickly and suddenly, and that is definitely the case with acute lymphocytic leukemia. Opposite of chronic lymphocytic leukemia, 80% of all children who develop leukemia have this type of leukemia, and it's primarily between the ages of 3 and 7, but fortunately it's highly curable when it is found in children. Like I said, the onset is very sudden, and it's marked by fever, leukocytosis, bone pain, and increased infections. What happens in this situation is cancerous cells begin to crowd out the other bone marrow cells, and because bone marrow produces red blood cells, we're going to see a decrease in the production of red blood cells and platelets. This is going to lead to anemia, and as this cancer increases, and we're going to see swelling in the lymph nodes, in the spleen, and in the liver. So in the groin, the neck, in the axilla, we're going to see swelling there. Those are places where we find large collections of lymph nodes. The spleen may also be palpable in the abdomen. So we basically treat this the same way as we would treat chronic lymphocytic leukemia with chemotherapy, radiation, and then also bone marrow transplants and stem cell transplants. Moving on to chronic myeloid leukemia. This type of leukemia accounts for approximately 20% of all cases of leukemia, and typically occurs most often in adults between the ages of 25 and 60 years. It is a very slow progressing type of leukemia. Early symptoms might include fatigue, weakness, weight loss. Some of them may be nonspecific or inexplicable. Diagnosis is often made by the discovery of increased granulocytic cells, and as a reminder, those types of white blood cells are neutrophils, eosinophils, and basophils. So we're going to see an increased elevation of those types of red blood cells, and the spleen is going to be severely enlarged. Now, in 70% of the cases, bone marrow transplants can cure this type of leukemia, and there is also a drug that has been invented that has advanced the treatments of chronic myeloid leukemia as well. Lastly, we're going to talk about acute myeloid leukemia. This type of leukemia accounts for 80% of all acute leukemia cases in adults and 20% of all acute leukemia cases in children. And because it is acute, that tells us that the onset is very sudden, and once symptoms appear, the disease progresses rapidly. Typically, patients complain of fatigue, bone and joint pain, bleeding gums, symptoms of anemia, and recurrent infections. Unfortunately, the prognosis with acute myeloid leukemia is poor, with only about 50% of children and 30% of adults achieving long-term survival. However, advances in bone marrow transplants and stem cell transplantations have increased cure rates in some patients. Infectious mononucleosis is often referred to as the kissing disease, so you might have heard it called that. It is typically caused by a virus called the Epstein-Barr virus, and it lives in our saliva. And this is why it's called the kissing disease, because you can get it from kissing, but you can also get it from drinking after someone that has it, or using someone's straw that has it, or toothbrush, or fork, or spoon, or anything like that, where saliva is being transferred from the infected person to another person. Typically, this causes an increased white blood cell count between 12,000 and 18,000 cubic millimeters. Typically, symptoms of mono are fatigue, sore throat, rash, enlargement of lymph nodes, and the spleen. Typically, it resolves itself within 4 to 6 weeks. However, in individuals with a weakened immune system, it can carry on for a longer length of time. So now we're going to spend a few minutes talking about the blood clotting process. So the process of stopping bleeding is called hemostasis. And this is a big buzzword in surgery because we always want to prevent bleeding, because bleeding has negative consequences for our patients. So what happens when an injury occurs? The first thing that's going to happen is that those vessels that are near that area are going to start to constrict down. This is called vasoconstriction. So this is going to reduce the flow to the area of injury. The next thing that's going to happen is damaged tissue cells are going to release various clotting factors into the plasma, that liquid part of the blood. And these factors are going to react with other factors that are already in the plasma, and they're going to form something called prothrombin activator. Now, typically the lining of the vessels is very smooth, and that's what we want, but when an injury occurs, it kind of makes this little rough spot, and that attracts platelets to that site, and the platelets start to stick there, and more platelets start to stick to those platelets, and here we're starting to form something called a temporary platelet plug. Now, as the platelets accumulate, they continue to release additional clotting factors and chemicals that's going to form even more prothrombin activator. This is kind of an example of a positive feedback loop. Now, if there's an adequate amount of calcium that's present in the blood, then the prothrombin is going to trigger that next step of the clotting process by converting prothrombin into thrombin. Okay, and that thrombin is going to react with another clotting factor called fibrinogen, and that is going to cause a change in that platelet plug, and it's going to kind of gel together and become this kind of tangle of fibers that we refer to as fibrin. All right. In surgery, or prior to surgery rather, physicians often give patients vitamin K. And the reason for this is that vitamin K will stimulate the liver to increase the synthesis of prothrombin, which we just learned is a very important factor in that clotting process. So knowing the way that blood clots allows us to alter that clotting process or mechanism when we need to. One way is applying pressure to the surface of a wound. I mentioned increasing vitamin K so that there can be an increase in synthesis of prothrombin. Another pharmaceutical that delays clotting is called Coumadin, and there are other various pharmaceuticals that do inhibit that clotting process. Heparin is another one, and heparin inhibits conversion of prothrombin to thrombin. There is also a drug called TPA, or tissue plasminogen activator, which is used to dissolve a clot that's already been formed. So this is if we know that the patient had a stroke, we can give this right away, and that will help to dissolve that clot. In surgery, what can we do? Well, there's a few different types of coagulants or methods that we can use for achieving hemostasis, and those three methods are chemical, mechanical, and thermal. Chemical meaning we're using some type of chemical, mechanical meaning we could be using a clamp or some sort of pressure device, and then lastly is thermal, which means we are using some form of heat. And here are some examples of those hemostatic mechanisms that we might use in surgery. Starting at the top left, this you will recognize as the ESU, and the Bovie pad and the Bovie pencil is there. So that's an example of thermal coagulation. And then moving across the top, Tisseal is a chemical type of coagulant. And then to the far right on the top is something called Surgisil, which is also a chemical coagulant that looks like a piece of gauze, but it really is made out of fibrin, and it helps to stop bleeding. Another example of mechanical hemostasis is in the middle to the left here. These are hemoclip pliers and hemoclips. And they're just these little metal clips that we can use to apply to the vessel so that it will occlude it. In the very center here, gel foam. This looks like a piece of foam, and it is a gelatin sponge that helps to stop bleeding. On the far middle right is Avatine. Avatine is kind of a weird substance. It's not a powder, but you can kind of squish it into a ball, and it is also a good coagulant that we can use in surgery. On the bottom left here, this is bone wax. If you ever had braces and they gave you wax to put on your braces, this is what they're giving you. It's beeswax, and it has been sterilized in this little package, and we can use it to put on the ends of bleeding bone to help it stop bleeding. On the bottom middle, these are silver nitrate sticks, and they kind of look like long matches, but the match head is actually a chemical called silver nitrate, and it chemically cauterizes tissue. And then on the bottom far right, here you will see a suture ligature, or just a suture material without a needle. And the surgeon can use this to clamp a vessel and then put this tie around it to ligate something that is bleeding. So these are some different things that you'll see in surgery that you'll definitely use in surgery. A prothrombin time test, or PTT test, is used to regulate the dosage of anticoagulants. So if we need to anticoagulate a patient, a good reason for doing this would be if the patient has a history of atrial fibrillation. If the top chambers of the heart, the atria, sometimes they don't beat the way that they're supposed to, and they kind of quiver instead. The risk is when the atria transition from that quivering back to a normal beat, there could be residual blood that's sitting in those chambers that has clotted. And so that first regular squeeze of the atria could actually push that coagulated blood through the circulatory system, causing an embolism. So we want to anticoagulate these individuals, and to know the adequate dose, we do something called a prothrombin test time. How we do this is we take calcium and thromboplastin and we add it to a tube of the patient's plasma, and then we see how long it takes for it to clot. All right. There is highly variable results among labs, so they are required to use something called an INR, and you might hear prothrombin test time referred to as an INR, and that stands for International Normalized Ratio, which is used to calculate and to standardize those measurements associated with the prothrombin test time. So we're coming into the home stretch here. We're going to talk about a couple clotting disorders. Two terms that you will hear used frequently in surgery is thrombus and embolus. And a thrombus is a stationary blood clot, as opposed to an embolus, which is a circulating blood clot. So if you have some sort of stationary clot and a piece of it breaks away and starts floating through the circulatory system, that is referred to as an embolus. And as the vasculature gets smaller and smaller, there's a risk of that embolus getting stuck somewhere downstream, and that can cause a difficult situation for the patient, a harmful situation. So surgically, how do we treat these? Well, we typically try to use a long catheter with a tiny little balloon on the end called a Fogarty catheter. If you've ever heard of Roto-Rooter, it's used to kind of snake the drain if there's a clog in your plumbing somewhere. This is a similar thing that we do with this Fogarty catheter, where we will pass that long catheter up through the vessel and pass that clot, and then inflate the little balloon, and while it's inflated, pull back on that catheter and hopefully pull that clot out. In the olden days, they used to just slice you open and take it out, which was very invasive, as you can imagine. But Dr. Fogarty took a urinary catheter home and a pair of gloves, and he manufactured something that resembles what we use today as the Fogarty catheter. And it's amazing because it's a lot less invasive for the patient, and it is extremely effective. Hemophilia is an X-linked inherited disorder, so that means it's attached to the female chromosome, right, the X chromosome, and it results in the inability to produce a clotting factor called factor VIII. This is the most serious bleeding disease worldwide. Hemophilia A is the most common form, and it is characterized by the individual will bruise very easily, they'll have deep muscle hemorrhages, there could be blood in the urine, they could have repeated episodes of bleeding into their joints, which could cause pain and deformity. So how do we treat this? We give factor VIII. We ask them to be very careful and avoid injuring themselves, and also avoid various types of drugs that could increase bleeding, chances of bleeding, like aspirin, vitamin E is another one as well. All right. So in regards to bleeding disorders in surgery, as you can expect, we want to be very gentle with the patient. We want to make sure that we're not resting anything on them. We want to be very cognizant when we're positioning them or retracting their tissues or handling them in any way. Thrombocytopenia is another clotting disorder, and it's characterized by reduced platelet counts. And what we will see manifested in the patient as far as signs is these little purple spots that we call purpura. And another sign is, like I said, a reduced platelet count below 20,000 millimeters cubed, which could cause catastrophic bleeding, which you can imagine if we bring one of these patients into surgery, that could be a catastrophic event if it's something that isn't treated and something that we don't know about. The most common cause is bone marrow destruction, and that could be caused by various drugs or chemicals or radiation or various diseases that are listed here. Treatment is going to involve giving platelets. Also, corticosteroid type drugs have helped, and then in addition to that, the removal of the spleen could be helpful. As we talked about before, vitamin K is needed to produce several important clotting factors in the body, and deficiency may lead to impairment in clotting mechanisms. Vitamin K is produced by bacteria in the intestines called E. coli, and it's also important to remember that, and we see this in a lot of situations where infants, their immune systems aren't fully developed when they're born, and various other factors, and one of those is also related to the production of vitamin K. So it's important to remember that they might not have as adequate of a clotting system as an older individual would. That concludes our lecture on blood. Thank you for listening.